Welcome to The Explainer. Today, we're playing medical detective, and our target is a real silent killer, a dangerous infection that seems to pop up out of nowhere, especially in patients with serious liver disease. So, how can a deadly infection appear from absolutely nowhere? Well, that is the central mystery of something called spontaneous bacterial peritonitis, or SBP for short. It really feels like it materializes out of thin air, but the truth is, it's a lot sneakier than that. All right, let's dive right in. First things first, we've got to define our culprit. And believe me, in this case, getting the identity wrong isn't just a simple mistake. It can be absolutely fatal. So, spontaneous bacterial peritonitis, or SBP, it's an infection of what's called acidic fluid. That's the fluid that can build up in the abdomen when someone has advanced liver disease like cirrhosis. And the key word here, the one you've got to remember, is spontaneous. It means there's no obvious cause, right? No ruptured appendix, no hole in the gut that a surgeon can just go in and patch up. And that right there, that's our first huge clue. SBP is a medical emergency. You treat it with antibiotics. But its evil twin, secondary peritonitis, is a surgical emergency. And if you mix those two up, the consequences are dire. That's why figuring out which one you're dealing with is so critical. Okay, but here's the thing that makes our detective work so tough. SBB is a true master of disguise. Sure, it can show up with the classic signs, fever, belly pain, maybe the patient gets more confused, but a lot of the time the symptoms are super subtle, or there are no symptoms at all. This means you have to be suspicious from the get-go. It's got to be on your radar. So if there's no obvious break-in, no forced entry, how in the world does this infection even start? Let's follow the trail and see how these microscopic bad guys get inside. The whole process has a fancy name, bacterial translocation, but think of it like a 4-step prison break. See, in someone with cirrhosis, the gut wall can get leaky. It's not as strong as it should be. This lets normal bacteria from inside your gut escape, get into the bloodstream, and then they travel and set up camp in that acidic fluid, turning what should be a clean space into a breeding ground for infection. For the longest time, the usual suspects were bugs like E. coli, but the lineup has been changing. We're seeing a lot more of what are called gram-positive bacteria, things like strep and staph. And why does that matter? Well, they're a whole different class of germs, and you need different kinds of antibiotics to fight them. It really complicates things, especially if the patient picks up the infection while they're already in the hospital. Okay, here is a golden rule for our investigation. You have to remember this. SBP is almost always a one-man job, a lone wolf. It's caused by just one type of bacteria. So if the lab report comes back and says they found a whole crew of different bacteria, alarm bells should be going off like crazy. That's a massive red flag that you're probably looking at a totally different crime scene, like a perforation in the bowel. All right, so we know what to look for. But how do we get the actual hard evidence to prove it? Let's get into the forensics of it and see how we can crack this case. The number one tool in our kit is a procedure called a diagnostic paracentesis. It sounds complicated, but it's really just taking a small sample of that abdominal fluid with a needle. And the key is you have to be willing to do it often. Pretty much any patient with cirrhosis and ascites who comes into the hospital or who starts to seem even a little bit sicker, they need what we call a tap. So, once you've got that fluid and you send it off to the lab, the entire case, literally everything, comes down to one single incredibly important number: 250. That's it. A neutrophil count of 250 or higher in that acidic fluid, that's the smoking gun. Neutrophils are like the first responder white blood cells, the body's SWAT team. If you find 250 or more of them in that tiny sample, you've got your diagnosis. It's SBP. You can and you should start treatment right away, even before the bacterial cultures come back. Now, there are other clues in the fluid that help us tell SSB apart from its dangerous look-alike. With SSB, you're usually looking at that single type of bacteria, low protein, and pretty normal sugar levels. But if it's secondary peritonitis, the picture changes completely. You see lots of different bacteria, the protein is high, and the glucose or sugar is super low. Why? Because that whole gang of bacteria is just gobbling it all. Okay, so we've identified our culprit. It's SVP. Now what? Well, the response has to be fast, and it has to be powerful. It's a two-pronged attack to take down the threat and control the damage. Part one of the counterattack is hitting it hard with antibiotics, and hitting it fast, even before you know exactly which bug you're fighting. Now, if the person got sick out in the community,
A standard, heavy-duty antibiotic is usually the right weapon. But if they picked it up in a hospital or clinic, you gotta bring out the big guns, something with broader coverage to handle those potentially nasty, drug-resistant bugs. But here's the kicker. Just killing the bacteria is only half the battle. The infection itself sets off this massive inflammatory storm in the body, and that can cause the patient's kidneys to just shut down. It's a deadly complication, and it's something we have to prevent. And that brings us to the second prong of our attack, a truly life-saving move, giving IV albumin. For patients who are at high risk, this one thing is an absolute game changer. Just look at the numbers. It slashes the death rate from almost 30% down to 10%. It works mostly by protecting the kidneys from all that inflammation. So we've dealt with the immediate crisis. The infection is under control, but job's not done. The final step is to make sure this bad guy can never, ever come back. We need to build up the defenses for the long term. This is what we call prophylaxis, or prevention. The reality is, once you've had SBP, your risk of getting it again is sky high. So to stop that from happening, these patients need to take a low-dose antibiotic every single day for life. Think of it like a permanent bodyguard, a shield to prevent another attack. So what does this all teach us? When a body's defenses are down, how do we spot the enemy hiding inside before it's too late? Well, the whole story of SBP is a perfect reminder that in medicine, the most dangerous threats, they're often the ones you can't see. They don't leave a trail of clues. It takes constant vigilance and a healthy dose of suspicion to save a life, and realizing that sometimes the whole entire case can be solved with just a single number.